Good evening, everyone. Welcome. We are thrilled you are here to focus on a very important issue, Ebola, the crisis that we are confronting, and the kinds of challenges that we see going forward. Before I begin, I'd like to thank those who were involved in putting the forum together in such a timely way on such an important topic. The Institute of Politics, who is our host, but is co-sponsored as well by the Harvard Humanitarian Initiative, the Program on Crisis Leadership, and the Harvard School of Public Health, who we should congratulate on their extraordinary gift that was announced only today. We've invited our guests here today to get an insight on the disease and talk about the progress in informing the public, both in this country as well as around the world, and stemming the disease in Liberia and other parts of Africa. We want to hear about the coordination that is required with neighboring countries and with NGOs who've played such an extraordinarily important role in what's occurred so far, and learn how Harvard can, in fact, help inform these efforts and help participate in finding solutions. As of September the 5th, 3,960 cases of Ebola have been identified by the WHO in West Africa, of which 2,105, in fact, are deaths as a result. It is the largest outbreak of Ebola in history, although it believes, WHO, that the number of cases may in fact be far greater than those that have been reported. As with previous Ebola outbreaks, the number of cases, again, the fatality rate is high, about 51%. The Director General of WHO declared the Ebola outbreak to be a public health emergency of international concern. That is only the third time such a declaration has been made. Previously, once in the case of polio and once in the case of H1N1. The outbreak has affected Ghana, Liberia, and Sierra Leone most dramatically, although Nigeria has now also reported a case that has occurred. And in today's New York Times, we see a recent report by WHO suggesting the crisis is even greater than we imagined in Liberia. The lack of experience with Ebola in West Africa, the emergence of the virus in remote border regions of all three countries, the unprecedented spread of Ebola to large cities, and the reports of relatively lax enforcement in some places are all challenges to the ability of countries with very fragile health systems to implement the kind of public health initiatives and countermeasures that are necessary. Questions have arisen about international organizations and wealthy governments, whether they have done enough or too little. And of course, the people in this country, many of whom had never heard about the Ebola virus before this occurred, have wondered about the risk to the US, given the lengthy incubation period and the ease of global transportation. Finally, issues have arisen as to whether or not it is ethical and appropriate to provide experimental drugs that may have only been tested in non-human primates and to be made only available to a few. We have people with us today who are uniquely knowledgeable about these issues and can help us understand them, about how the disease is impacting West Africa, what is being done, and what should in fact be done. We are particularly privileged to be joined by the President, who is with us on the screen. She was elected 9 years ago by the people of Liberia. She has generously joined us by video in an undoubtedly busy and very challenging time for her. She is one of our most distinguished graduates of the Harvard Kennedy School and is our only graduate to have received the Nobel Peace Prize. She has been a remarkable leader facing extraordinary challenges, tackling economic turmoil, corruption, national security, and her effort to revitalize Liberia. She is the 24th president of Liberia and the first elected female head of state in Africa. She is serving her second term as president. We are extraordinarily pleased that you are with us, Madam President, and so grateful for the time that you're able to give us today and this evening. Also joining us, Michael VanRooyen, the director of the Harvard Humanitarian Initiative and the vice chairman of emergency medicine at Brigham and Women's Hospital. He has served with numerous relief organizations in over 30 countries, has helped the Red Cross at the site of the World Trade Center in 9/11, and in response to Hurricane Katrina. We also have Dr. Dyann Wirth, the Richard Person Strong Professor and Chair of the Department of Immunology and Infectious Diseases at the Harvard School of Public Health. She is a major leader in the area of malaria research, and together with partners in the malaria community, involved with new academic efforts at the university to promote the information regarding the production and the transmission and translate knowledge to support the control of malaria in this country. The president is only able to be with us for about 25 or 30 minutes. So I'd like to begin with her. Our intention is to have a discussion among the panel and then to open it up for questions. Madam President, thank you again for being with us. The first reports of the disease in Liberia came in March, and by June, the suggestion was that it moved to Monrovia. We are interested in what is in fact occurring, the kinds of progress that has been made, and your thoughts as to what we might do going forward. Madam President, please.
I'm very glad to join you all, and thank you for arranging this forum that will focus on Liberia. The pace of the incidents, its spread has so taxed our capacity to respond. And as a result, the numbers have increased so tremendously. Liberia is in the rather different position in that whereas in Sierra Leone and in Guinea, the epicenter of the incidents is in the rural areas. In Liberia is in our capital city where over 1/3 of the population reside. When it commenced, we had incidences in 2 of our 15 political subdivisions. It's now in 10 of 15. Different intensity, of course. The capital city has been the hardest hit. We have tried to cope with very limited support initially, and the fact that we have a population with different cultural and religious habits that did not give them the kind of caution that our health workers suggested, facilitated the spread of the disease as they moved around from one community to another, most times infecting others. We have now tried to strengthen our capacity, to redo our strategies, given the pace. And finally, of course, we are getting some support from international partners. Still far behind the need, but there is some improvement. At the same time, we have faced a situation in which our health workers have been affected. Doctors who treated persons not knowing that they had been infected, got themselves infected and died. So many of our nurses treating without the proper protection also died. And so we find today that we have over 2,000 suspected or probable cases and well over 700 deaths. Some 74 health workers have been affected and over 40 of them have died. Yet we have some success stories. I'm sure you know that some of the doctors who were infected here, who left and went to the US, they had been treated here and had recovered a little bit. And then, of course, with the additional medical service they received in the United States, they have survived. And today, we find that we're having some success stories with early treatment. We now have over 100 persons that have walked out of those treatment centers. Our big issues today are twofold. First, not enough facilities. We call them the Ebola treatment units. We started with Medicine Sans Frontier operating only 2 of those units. We now need to have space for some 500 persons, and in the process of trying to construct them. Testing centers, we had only 2 in the country, one in the capital city and one in the far rural areas. We now have, through CDC, we have a 3rd one, but that's still insufficient. And we're dealing with 10 different counties that have incidences. Not enough health workers, not enough experts in the areas. And those are the challenges we face. But we are continuing to work at them, to do training of our own people who can take some responsibility for being able to work in those treatment centers. We now have responses, we believe we'll be getting from the African Union, from the United States, some of our other partners, which have sent supplies, not enough of them, but still more supplies are coming in of a wide range of material that is needed to combat the disease. It remains a very grave situation, and it's taking a long time to respond effectively, but we've now set in motion some of those measures that should begin to see results. We expect it to continue to accelerate at least for another 2 to 3 weeks, but we hope by the new measures we put in place after that we'll see a stabilization and hopefully look forward to a decline.
Madam President, there has been recent information, both the UK and the US are bringing in military support to assist in setting up units, essentially clinical facilities. You mentioned as well you're getting support from the African Union. In addition to building capacity for the short-term problem, what do you imagine that you might do long-term with respect to both the number of physicians and other health providers, which has been a continuing issue in Liberia in terms of the shortage of providers and communities? What other kinds of initiatives might you imagine putting in place, and where do you imagine that support coming from?
You know, as a result of the Ebola virus, we have found that ordinary healthcare has been affected, partly because the healthcare workers who have been affected have been reluctant to respond to just normal healthcare, partly because most of our health services, facilities have been closed because of the fear. And so we see a deterioration in normal healthcare. That's where we can use some support. Just rebuilding those health systems so that many people who need care and who do not have Ebola will not lose their lives because of a lack of access to those services. We're hoping that some of these responses will bring us just doctors and nurses and healthcare workers, physician assistants that can man those units. And we've now identified some of our hospitals and clinics and health facilities that are going to focus on normal health care, rebuild it and lose the progress that we have made in healthcare delivery over the past 8 years.
One of the issues that you touched on were some of the cultural challenges that you faced, burial procedures and others that essentially are a tradition in your country that perhaps have exposed people to these circumstances. Education of the population, I know there have been signs posted suggesting that Ebola is real, trying to address what is apparently a concern as to whether people believed in fact it was a problem, that it wasn't in fact something made up. What progress has been made in terms of the education of the population, particularly in a city like Monrovia, which is so densely populated, issues that arose in terms of West Point and others? What kind of efforts are being made as well to educate the population generally so that they are receptive to the kind of interventions that you are trying to put into place?
First, I think we want to recognize that we have deep-rooted cultural habits. The extended family system, getting together, sharing things, sharing homes, facilities, being able to reach out to people, all part of our culture. We have strong religious feelings in which people have certain habits regarding the dead, whether you're from the Muslim community or the Christian community, they're accustomed to having some kind of a ceremony with the dead. And so all of those have impeded some of our attempts to change the culture in that regard. Now, I must say that through our educational and awareness effort, there's been some progress. Liberia has never known cremation. But today, because the pace of the incidents have resulted in so many deaths, the population have accepted that that is the only way to be able to dispose of the dead in a very safe fashion that would not put others at risk. So we're continuing with the awareness. We're continuing to change these long-standing cultural and religious habits. It's taken a long time because there was just complete disbelief. There were even some views that these were either the government or partners of the government bringing this strange disease to them. They resisted. Sometimes they even attacked health workers and partners because of this resistance. But like I said, we've been working on this. We're trying to make sure that we have community ownership, community participation, so that they themselves can take responsibilities to identify the sick in their midst and to make sure that they're sent to healthcare centers for early treatment. We haven't overcome yet the denial and the resistance, but we've made a lot of progress in that regard. And this is, again, why the incidence has gone up. Whereas before they were hiding and running away from it, today our message is reaching through that if you find someone is sick, please report it very quickly. Please take them to one of the health centers very quickly. And they are responding again beyond our capacity to respond by giving them the access that they need. And so this is why we're building new treatment centers. And this is why we still say we have to stop the spread of the incidents. We have to do more for prevention. We have to do more for community awareness. We have to make sure that communities take ownership of this and begin to work on it themselves. And that's what we're trying to focus on.
Madam President, I'd like to ask my colleagues on the panel who may also have a question for you, if I could. Mike?
Sure, Madam President. First of all, thank you for your courage and leadership and decisive action in the face of this epidemic. I wondered if you could comment on your concerns about the economic implications, sort of the trade implications, the cross-border implications of the epidemic, and as you see it affecting the economy.
We're very, very concerned about that. Because while we're concerned with life, we also know that the consequences, both short and long term, of the Ebola virus could be livelihoods would be at risk. We've seen the decline in our growth projection already, whereas we expected some 5.4% this year is now going to be reduced to about 2.4, 2.5. We've had so many of our large corporations that were involved in expanding their mining and agriculture activities. They have had to either slow or close down their operations, and most of their staff have left. We also have our cross-border trade. Many of our market women go across the borders to be able to exchange commodities. They can no longer do that because the borders are closed. This is putting pressure on the exchange rate, as we don't have as much dollars in circulation. We're facing an unmilled drawdown, with some of them leaving in a very planned exit strategy, but that's also affecting the economy. Many people have just left. Some of our own citizens, have left, or those from the diaspora that were returning home have either gone back or have decided to delay their return to join us in reconstruction. Much of our development work, our power systems, our road systems, our health systems, for which we had good plans for making more progress than we have also been affected because we've had to slow down. So the consequences are enormous. We are now beginning to look at some mitigants for the short-term consequences, and that we're engaging some of our partners, the IMF, the World Bank, the African Development Bank, for special facilities that will enable us to make sure that we continue to meet basic services and continue our programs. And in the longer term, we have to attract back all of these companies and create an environment that will make them feel confident and safe to return to the business, so that the economy will pick up. But it's going to cost us quite a bit, and it will take us some time for us to get back to the level of progress we had achieved, and hopefully make even more progress in keeping with our long-term development goals.
Madam President, if we could ask one final question. Dyann, would you like to?
Yes, Madam President, thank you very much for joining us. And again, I am in awe of your ability to take both leadership and still keep in mind the vision for your country. And in that regard, I wonder if you might tell us, looking past this current situation, what the leaders in your community, in the Ministry of Health and in the medical community and more broadly, think in terms of the importance of Ebola going forward. Should the world community devote effort to vaccine and drug discovery? As you know, this is a disease that has, in the past anyway, had a relatively minor number of people. Obviously, the death of anyone is a serious problem, but a relatively small number of people. Yet here we see a larger outbreak, and potentially a very large outbreak. And I think one of the things that, one of the real questions is how to prioritize in the face of many other medical and health problems.
We believe that the response to this virus, which started in DR Congo in the 70s, has not been forthcoming. There have been so much research on biological diseases. That expertise exists in the United States, in other countries, but there hasn't been enough to find a vaccine and to test the vaccine. And so I believe that research has shown that there could be a reoccurrence. And so this reoccurrence has come. And we're far ahead in the incidences than in the means to combat it. We hope that the good side of this is that there will be accelerated effort to find a cure, to find a vaccine, to find a treatment, and we begin to see signs of that already. I think the timetable for testing by some of the companies involved in the research has been shortened. We've had the experience of using one or two of those and testing them, and they've worked in one or two cases. And so we hope that that's the good side, is that more resources will be put toward finding this vaccine, completing this test, and finally finding a cure for this. But it's going to take the commitment, the determination by our partners who have the expertise and who have the resources to make this work. We hope that that will happen, that the conscience of the world will be stroked by the tragedy that has been imposed on us by this, and that will lead to a response that will finally find a cure and make sure this disease does not affect any other place in the world.
Madam President, thank you so much for being with us this evening. I know it's quite late where you are this evening, and you've been great to give us the time, and we wish you the very best of luck. And again, thank you for all of your work.
And thank you.
We've had a terrific opportunity to hear how the President is facing this issue. But Dyann, I wonder if you might bring us back a little bit and talk a little bit about what we know about this disease since its recognition in 1976 and what has occurred since. Obviously, there are questions about the risk to the United States and to other countries in the region. Are we, in fact, as the President suggests, likely to see continued growth for the next few weeks and then a decline? What, in fact, do we know as a result of WHO and others?
Exactly. Well, I think the President gave us a very nice overview of the situation in Liberia. Just maybe to step back a little bit to remind everybody, this is a viral disease. It's a disease that we call a zoonotic disease. Its reservoir, the virus, lives in animals, so that's the source of the original infection. And in this particular epidemic, the work's been published from Sierra Leone, it looks like all the virus that's infecting people actually stems from a single transfer from an animal into a human. So there's a beginning case, and so once it enters humans, then the transmission is human to human, but it requires direct contact with the infected person, with their bodily fluids. So we consider this a disease that's not as contagious as something like influenza, which is passed via aerosol or via the air. But in areas where people infected come in contact with, as you heard, health workers and family members, you can see the epidemic starting and then spreading. And that's exactly what has happened here. We don't know precisely where we are in the epidemic curve. The epidemic curve, cases start out very slow, and then there's generally a rapid increase, an exponential increase, then usually a leveling off. And in the previous cases of Ebola, of Ebola outbreaks, there has been a diminution. So you see this kind of peak, plateau, and then going down. I think it's safe to say we're either in that exponentially growing phase, or perhaps in the plateau. There are two issues. One is, a number of people have hypothesized that the number of cases being reported, there's actually significant underreporting. And you may be seeing in Liberia, there's a large number of cases that have appeared in the last couple of weeks, but it may be that that's increased reporting rather than increased transmission. It's just very difficult to tell at this point. So that's where we are. I think in terms of risk to neighboring countries, obviously an infected person traveling, as you saw in the case of Nigeria, a person traveled to Nigeria using air transport and then was acutely ill and came in contact with a number of people, many of whom were infected. As far as I know, that's contained now, but of course, with limit, if someone's not reporting, then the same thing could happen elsewhere. So I think that's a risk, but I think that with good sort of recognition of the case, quarantining, contact, finding everyone who's had direct contact with the person, and then keeping them under observation during the incubation period certainly is the classic way of stemming such infectious diseases. There's there's hope, I think, on the vaccine side. There are 2 vaccines that are in, as the president indicated, in accelerated trials, and they're going to enter people once safety is determined in people. They will be, I think, deployed. There are also various treatments, including using serum from previously infected individuals. So there are kind of methods, but the reason I asked the president the question I did is I think this is an example of the kind of streamlining of investigation to things that affect either a large number of people or are important in a place like the United States. So this is one of those very neglected diseases. It affects a small number of people, and yet you can see that we've known about this virus since 1976, and yet the amount of kind of basic knowledge and that translation of that basic knowledge into treatment modalities is really behind the curve. And so I think that's a very important lesson from this, and I think something that we need to think about. There are obviously trade-offs. Working on Ebola that previously had affected a few thousand people in the world seemed perhaps not as important as working on something that affects many more people.
Dyann, I want to come back to you in a moment and talk about the traditional public health reaction, and you mentioned quarantine. And of course, the president attempted to put in place a quarantine in a section of the capital city, which lasted a very short period of time, had very dramatic results. It is a densely populated area. There was concerns about access to food, people essentially getting out of the secured area. You tend to think of it more in terms of relatively small areas, more easily contained. In a large city, there are different kinds of challenges. So I want to come back to that for a moment, but I want to talk, if I might first, Mike, there has been a sense that the international community has not responded as quickly as it might have, nor in a way that was as responsive to the scale of the circumstances. There are questions about what, in fact, the role of WHO is. You know, is it operational? Does it put boots on the ground? Where, in fact, does that responsibility lie? And what have we learned from this particular circumstance that has happened over a period of months, but the response seems to have been so slow? Your experience with those kind of responses, I think, would be quite helpful.
Sure, thank you, and thank you all for your interest in the topic. It's, I think it's going to be of ever-growing importance, actually, in the next weeks and months. First of all, I think it's important to know that the initial response to prior epidemics has been very focal, relatively aggressive, but relatively small as well. So it was, you know, a contained epidemic, and this epidemic, of course, has spread to, you know, several borders now, 5 countries, and it's become an international emergency. I do think that the recognition that this was an international emergency was quite delayed. So the international health regulations and the emergency committee of the sort of epidemiologic resources that the WHO came together, and only on August 7th, I think, declared this to be a public health emergency, whereas organizations like Doctors Without Borders, Samaritan's Purse, and other operational organizations that were working on the ground knew this to be very different, probably 2 months before. So in terms of the recognition of the consequences of this public health emergency, they were significantly delayed, I think. That being said, I think now it is clear that the international community, the WHO, the CDC, the NIH, and other organizations, including the World Bank, accept and understand that this is not only of global significance, not just West African and not just continental, but global significance, but that our efforts to date have failed. And I think it's going to be incumbent upon those organizations to help push forward a plan to make this public health and kind of international relief priority. I think there are certain attributes of this crisis that need to be understood, the response to this crisis that need to be understood. I had a meeting last week on Wednesday with Jim Kim from the World Bank and the Director General of the WHO, and in a relatively small room, the directors of CDC, NIH, and it was interesting because they were clearly and candidly and even publicly said that this epidemic is frankly out of control. The same thing that organizations like Samaritan's Purse and Doctors Without Borders have been saying. And I think that there's a few major priorities that need to be addressed. One is the massive scale up of public health messaging, communications, and education, to millions. And it has to be done not in a period of months or years, but in a period of weeks, really. Another one is the significant, as the President mentioned, the significant need for scaling up an international presence for curative health resources, so Ebola treatment centers, for example. The key to containment here is not the medical piece of it, it's the public health piece. But the beacon for treating individuals who are affected and to showing the rest of the country that you are treating people who are infected is extremely important, and that is going to take a large international effort. You mentioned the role of the WHO. It should be clear that the World Health Organization is a technical and advisory body. It is not an operational body. In other words, they don't send teams of people to staff treatment centers. They send teams of people to advise and to give educational advice, to give technical advice, to give treatment advice, but they're not a scalable they're not a scalable organization. That's going to have to come from either the international NGOs, particularly the experienced ones, and we can talk about that later why. MSF, Samaritan's Purse that did a really nice job, I believe, as well. International Medical Corps, IRC, Save the Children, all of those organizations, Partners in Health included, but also the military. And I think that there's a significant role for the military, although I'm not sure that there's a plan yet for boots on the ground, as it were. I'll leave it at that for now.
One of the challenges in that context is we're dealing in this case with countries that have so few assets to begin with. As I recall, the ratio of physician to population in Liberia is about 1 physician to 100,000 individuals. And of course, the concern is whenever you have a third party coming into a country, particularly a military presence, there is great concern given the suspicion, what the President mentioned in terms of their traditions, the concern about whether or not, in fact, we are creating the problem rather than solving the problem. Following the H1N1 situation, there was a post-action report that was done that recommended a series of steps. And one wonders, again, what the next steps might be going forward. That simply assuming that a military presence from either the US or the UK or any number of countries that have offered to do so solves a problem or creates a problem in terms of the long-term solution for these countries. But going back to the public health issues, the traditional response would be isolation, would be essentially trying to remove those individuals from the population. As the President suggested, there are a series of steps that are being taken in terms of removing those who are ill, putting them in facilities, which of course at the moment they don't have the capacity. But the community response, it traditionally has been to bring people home, to bring them back to their villages, where of course the issue of transmission becomes much more complicated. What effect have we learned in this case about those traditional public health responses, and do we need to think differently going forward about what one might do given the kinds of circumstances that we're confronting here?
Well, I think one of the issues is the knowledge base, right? I think that once people understand, and I think the President said this very clearly, once people begin to understand how transmission occurs, I think acceptance of those isolation and prevention of contact, that will start to change people's way of doing things, because this is, a relatively short, if you touch somebody who has Ebola, you will later be sick and have great risk of dying. So I think that but it's a knowledge base, and I think that's a challenge everywhere with health, is having people realize how transmission occurs. And in this case, it's not an aerosol risk, it's a direct touch risk. If you don't touch the infected individual, or their bodily fluids, you will not get infected. And I think that that's something which clearly one is, I think according to the president, one is starting to see in Liberia some understanding of that. But I agree entirely with Michael that this education piece, this understanding is going to be extremely important. And it's an uncommon disease, so it's not surprising that the population doesn't understand this. And I think it's also not surprising that there's fear that everyone that goes into a treatment center never comes out. I mean, I think there are clear reasons why people are continuing to get infected, but I think that is going to be one of the keys.
One of the issues in terms of the concerns here in the States is this question of the ease of transportation. And the incubation period, and whether or not you are asymptomatic for a long period of time and essentially present yourself without knowing you are in fact infected. And so one of the questions, of course, that's asked, I mean, the statements that have been made is our borders are secure, we have the ability to anticipate and prevent the entry of any individual who is a potential carrier. One would imagine, given those facts, that that's not likely to be, in fact, the case.
Yeah, I think that we have, however, a very good system for recognition and reporting. So, but there certainly could be someone who enters, who got infected and unknowingly and enters the U.S. With an infection, and I would guess there could be transmission here. So I think it's very important to realize this. I think it's very unlikely there would be anything more than the transmission to a very small number of people, and it would be recognized early, and there would be very active quarantine. That is the role of CDC and the state health departments. And that's why CDC was established, and it does its job, I think, quite well.
In terms of surveillance and reporting and identification, tracking.
Exactly.
And also health education, public health education. So I agree entirely with Dyann that I think, while it's conceivable that the Ebola, and probably will, breach our borders, public health education will prevent the rapid spread of that disease. Unlike, say, in Liberia, for example, where the rates of any febrile illness cannot be differentiated. So when people think they have malaria, they have a cold, they have any other febrile illness, it's impossible to distinguish between that and Ebola early on, and that's one of the fears.
Well, that's also will be true here also, yeah. But I think that the point is, travel history, febrile patients will be asked, have you been in West Africa? So I think that, but I don't think there'll be a large spread here, but I would be pleased, but surprised if there isn't some introduction.
Let me now turn to the audience for your questions. There are microphones on either side. I would ask that you identify yourself when you come to the mic and your affiliation. You keep your question short, and that there is a question mark at the end of your question. Let me begin on my left, please.
Hi, my name is Sylvia, and I'm a senior at the college. So one of the things I wanted to ask was, Liberia seems to have it worse than any other country that is dealing with the crisis, to the point where Dr. Dlamini Zuma, who's president of the AU, has to come out and say to stop travel bans into Liberia due to the economic impact it's having on the country. My question is, if that is the case, then what are other countries like Sierra Leone doing right in dealing with the crisis, if they're doing something right? Because it seems to have less of an impact. People are still being infected, but it seems that Liberia has it worse. Why is that?
Terrific question. Dyann?
We'd argue it went to the city, right?
Right.
I think that the most likely explanation is that in Liberia, it's in more densely populated areas, and so the opportunity for the transmission is higher. So I think that's probably the major, and whether that's just happenstance, or whether that's something about the differences in the way those societies interact.
And I would say the public health infrastructure of Sierra Leone is probably weaker, and so and the potential for you know, further spread of the epidemic within Sierra Leone, for example, or Guinea or any other place is certainly still there.
I mean, as we know, the first introduction was at the border areas that are relatively rural. And so the question as to how quickly it moved into the capital and what those transportation lines were like and commerce, how it traveled essentially, could well have brought it into a more populated area in Liberia than was the case in the other countries. Yes, please.
Hi, my name is Thage Nithalaganti. I'm a former graduate from the School of Public Health, a former student of two of the panelists. I currently work for the Clinton Health Access Initiative and have been involved in workforce planning for the health sector in Liberia. My question is about just the efforts of coordination. There's a lot of folks who want to help Liberia, help with the Ebola efforts, but the government has very low bandwidth and capacity to be able to coordinate so many different folks who need information and want to be able to have a helping hand, whether that be clinically, management, supply chain, et cetera. What would your advice be to help coordinate with the government and ensure that there's actually a focus, strategy, and plan to all of this?
Mike, you've been in similar situations in other countries. What would your thought be?
First, thank you for your work and your efforts. I think the issue of coordination always comes up when it comes to sort of a large-scale humanitarian emergency, right? So if it's a conflict, whether it's a large-scale disaster, the issue of coordination and the structures for global mobilization and coordination are in place. So the UN and the Office of the Coordination of Humanitarian Affairs, OCHA, has a cluster system. The cluster system is being activated, and that cluster system allows coordination along the health sector, the education sector, the food, water, sanitation, all of those issues. The difference is here that this is a medical and public health emergency that is quite different than the multi-sectoral response of, say, conflict or another disaster. So I think this actually will become multi-sectoral, right? It'll be a food issue and a food security issue. It'll be a migration issue. It'll be many of those other things. But right now it's a lot more technical. And so that technical guidance, the governments do not have the capacity to, they have the capacity to participate and to guide in a political sense, but in a technical sense, they are overrun. And I think that there's a significant need for technical coordination and guidance. There are going to be far fewer organizations that are going to play a role in this. You know, Haiti, for example, a month after, or 2 months after the earthquake in Haiti, there were 13,000 new NGOs that showed up to Haiti to help or be there, whatever they did. And I'm guessing those organizations are not going to be showing up to Liberia and Sierra Leone. Matter of fact, probably only the very experienced organizations that have operational capacity in healthcare are going to be able to be there. And those are going to be, I think, easier to coordinate, but it'll be a challenge for the government for sure.
Right, because you're going to need the technical expertise not to make the problem worse, right? Not to increase transmission by, you know, transporting patients or whatever. So I think you're absolutely right. You need people that have the skill set and the knowledge set and have worked in such settings too.
And might I just add, and you know, as you think about scaling up manpower resources and healthcare manpower resources, I mean, that's what I'm doing right now. And these days, I'm sort of trying to mobilize the healthcare network of the United States, my colleagues essentially, to fill those posts with NGOs. But I'm doing it with some trepidation because the level of vigilance around infection control has to be so tight and so well trained that many organizations don't have the capacity to do that.
The risk to individuals is very high.
Yeah, it's not. It's the varsity. It's really a very important training moment for NGOs.
But you raise an important question in that context, and that is that in addition to the health services, one of the issues that arose as a result of the president's efforts was the absence of food and clean water because it couldn't get into the quarantined area. So at what point do those issues also become dominant? and that is the extent to which you can get a health infrastructure in place. You do have to feed people, you do have to provide clean water, you do have to provide essentially the other resources necessary to support them during this period of time. Who steps in and provides those assets?
I mean, I would say the same. So I think this will move from a medical and a public health emergency to a larger multi-sectoral emergency eventually. Because at the point where food prices go out of control because of borders are closed, lack of food resources, difficulty in accessing and delivering food, and then population migration, then we're talking about a different scenario altogether. So I think that the rush really is to try to control the epidemic before there's food insecurity and population migration.
Right. Remember, now there's still relatively small number of people infected. Even if it goes to 20,000, that's not a large number of people in the population. So it is important. I think you're right. Right now, it's important to control the epidemic.
Yes.
Thank you for sharing your insights. This is really helpful and valuable and very interesting. My name is Maya. I'm a first-year student at the MPA at the Harvard Kennedy School. My background, I'm just coming from the Global Fund, but also working with the Clinton Health Access Initiative. I would like to go back to the topic of prioritization of resources. That's something that I've spent a lot of time thinking about. What I would like to pose and just hear a little bit more of your thoughts on is, as was mentioned, not a lot of research and investment has been put into the vaccine, to treatment for Ebola. But there's a lot of other diseases and viruses that also have not been invested in and so on. So we have the most resources we've ever had for global health at this moment in time, but there's still a lot of competing priorities. And so I think coming out of this, there could be a potentially knee-jerk reaction to invest a lot of money in Ebola, whereby not necessarily taking a larger, fuller scale picture and what are the underlying reasons for why Ebola surfaced in countries like Liberia or neighboring countries. So I would just love to hear your further thoughts on how do you think globally we should be thinking about prioritization of resources into global health, and should we be investing in individual vaccines or diseases, or should we be more fundamentally building health systems that will better enable countries to react to whatever challenge they may face?
Right. Maybe I'll start. I mean, yeah, I think it is important to put this in perspective. I mean, in the period since the beginning of this current Ebola crisis, just to use malaria as an example where I do know something, about the estimate will be around 300 to 400,000 children under 5 have died of malaria in this same time period that 2,000 people have died of Ebola. So I think it's very important to have this perspective. On the other hand, I think and that's true, you could do that for tuberculosis. There are many diseases where the burden of the disease is much greater than it is for Ebola, and where the countries like those affected by Ebola are disproportionately affected by those diseases. The number of people that die of malaria in the United States is is very small and is usually just by misdiagnosis. And so, I think that it's a question we face every day, but I do think that it is very important, and what I try to say to people in thinking about this is these are, treatable, preventable diseases, and that having the right tool to do that will actually change how the population deals with this kind of infection. And so I don't have an answer for you. I mean, but I do think that you need research and investment and implementation that is disease specific, because these are the diseases that are killing the population. And I think that if there were a vaccine, my understanding for Ebola is it may be quite straightforward to get a vaccine. It's a type of virus for which vaccines have traditionally worked. And in that case, a relatively small investment might actually have a dramatic effect. I think the risk of emerging diseases and viral diseases is going to be with us forever. I mean, many of you will remember the SARS epidemic. Same story, you know, here's a virus that no one has worked on for years because it hasn't been a human health problem, and all of a sudden it, you know, changed, you know, Harvard, but I didn't cancel graduation in the end, I guess. It made everyone shake hands with their elbows, and, you know, there were all sorts of, you know, reactions to this which were disproportionate to the problem. But I think, again, this is something we're going to continue to see. So I don't have a good answer for you, but I think it's a nuanced question. So, I mean, you know, do I spend money on malaria or do I spend money on Ebola? I think it's a tough choice, and I think we have to think hard as a community about that.
Hello, my name is Bianca. I'm a junior at the college, and I interned at the HHS Office of Pandemics and Emerging Threats this summer. My question relates to something I think you touched on a little bit beforehand, with regards to healthcare workers not knowing whether or not their patients initially were infected with Ebola and ended up actually being affected themselves. And that makes me wonder about diagnostic tools and whether or not there are, well, I guess, what diagnostic tools are currently in place and whether or not there is a significant enough support structure in these countries for these diagnostic tools, and kind of if you think that we should be focusing on this, or if maybe we should be you know, directing our attention elsewhere.
Do you want to take diagnosis?
Sure. You know, in terms of diagnostic tools, there are diagnostic tools. There's actually an effort by one of the faculty members here in the Faculty of Arts and Sciences, Pardis Sabeti, to look at fevers of unknown origin in Sierra Leone, and so she actually her group was set up to do the diagnosis based on nucleic acid. So there's a definitive diagnosis, but there's not a rapid diagnostic. So you can't actually tell, you know, with the patient in front of you. It has to go out and it takes some time. And these are, you know, this is a hemorrhagic fever. That means it's a bleeding disease. So these are urgent, as I'm sure Michael can tell you much better than I. This is an urgent medical problem. So you can't, there's not a diagnostic available that can diagnose at the site. So I think the practice is to assume in those areas Ebola until proven otherwise. But if you practice universal, you know, gloves, coats, face mask, the risk is greatly reduced. It's not zero, but it's greatly reduced.
I might also comment regarding the transmission issue. I think, first of all, testing sites are important to establish testing sites, but Diane's right, it takes, you know, anywhere from 8 to 36 hours to get a test back, right? So when you get people who are presenting en masse to a screening facility with a febrile illness and you need to test for that, it's inconvenient not to have rapid testing, and there are some attempts to establish rapid testing. I'd also say, though, that we may have to get out of the spacesuit mentality, in that we know how this disease spreads, and if you can maintain appropriate universal precautions to do so, you don't necessarily have to have a spacesuit, right? We can have actually health workers and family members with soap and gloves and bleach and, you know, aprons, and be able to be vigilant about their knowledge of how this gets spread and how it doesn't. I think we're going to have to move away from just either spacesuits or nothing, in terms of kind of managing the risk.
And in fact, one of the efforts is to provide those basic tools and to send people back into their communities with gloves, with aprons, with masks, with bleach, but also teach them how to use them. And that's been one of the challenges in these countries, is essentially equipping people with even those basic tools.
And educating
them and how
universal
to use
precautions.
Exactly.
And there's going to be a discussion, I'm sure, and nobody's really talking about it much now, but it's going to happen, that as health services in certain regions become overwhelmed, and that screening facilities people are simply not going to go to because they're places where they're at greater risk, home care actually will be
Leave it in their communities.
a newer innovation when it comes to this. Years ago, probably 1999, WHO promoted, if patients are refusing to go to the hospital, to educate people for home care. We will see, I think, in the future that home care options where families are educated, they can contain and manage the disease at home through hydration and appropriate management will happen. So I think we'll see that in the next month or so.
We are going to run for a few minutes longer than our appointed time, so we're going to do a lightning round to try and address as many of the questions that we have. And I'll ask our questioners to keep their questions short and our respondents to keep their responses brief, and we'll try and deal with you as many as we can in the next 5 to 7 minutes. So let me go to my left.
Okay, thank you. Good evening. My name is Joseph Luna, and I'm a PhD candidate at the Department of Government. I wanted to ask a question about the local citizens who have survived having Ebola. Namely, are they being recruited into any of the educational programs to convince the non-infected or the currently infected to adhere to the rules of quarantine?
Good.
From my experience, both expatriates, of course, in the very narrow sense, and national, especially healthcare workers who have been survivors and know of survivors, have probably not been mobilized as much as they should. They should be poster children, and they should be celebrated. And I think part of this is going to have to be, really recruiting them back into the workforce.
My name is Alexa, and I'm a mid-career MPA here at Harvard Kennedy School. This seems very reminiscent of what was happening in the 1960s with smallpox. It's a very highly contagious disease, and thankfully it was quarantined and it was contained by people in like Larry Brilliant working in India. The beauty of that containment, the beauty of that method was that there was a vaccine against smallpox, and they were able then to basically knock door to door, quite literally, in order to contain the epidemic. My question is, you talked briefly, you mentioned the vaccine, but if you could talk a little bit more about the Ebola vaccine, and if there's controversy associated with it, any particular controversy also or contention from the private sector, if you could just inform us a little bit more on that. Thank you.
Okay.
Right.
Dyann?
Well, the vaccine is experimental. It's, as I understand it, it's expressing Ebola proteins in a slightly less virulent virus. It's been tested in non-human primates and shown to be effective. It's currently undergoing safety testing, but if it is deployed, assuming it's safe enough, and Tony Fauci, the director of NIAID, seems to have, is encouraged by the results, it will, I think, be deployed without a classical clinical trial, because this is, of course, a disease where a clinical trial would be difficult to assess, and that raises its own ethical issues, but I think because of this public health emergency, I think that is the route that people will go. So should it work, I think there's hope. I think it's very early to say. The number of, individuals, non-human primates that have been vaccinated with this and tested is very small, so that there may be things we don't know. The smallpox vaccine had much more testing before it was widely distributed. So I think there's risk.
My name is Rachel, and I'm a graduate student at MIT. I have two related questions. First of all, you spoke very eloquently about how the efforts to contain the epidemic so far have failed and how the outbreak is currently out of control. And I was wondering if you have specific suggestions about what sort of efforts might help contain the epidemic, and also especially whether Liberia and other countries have made specific requests of the international community. For example, I know recently there has been some discussion in the public health community about deploying hospital ships from the U.S. The U.S. has 2 hospital ships that have 1,000 beds each, and I was wondering if that's a sort of intervention that you would consider effective, and what interventions you might consider most effective. And my other question is, since we are an audience of students and people from the Boston area, whether you have suggestions for students or for the general public about how one might encourage a more robust response, and what kinds of actions on the part of the general public you would consider to be most useful.
Rapidly asked. 4 questions at least.
Really? Excellent,
done.
right.
Yeah.
Quick response.
Treatment facilities, first of all, I think that the international community is gearing up to respond heavily. However, I've not seen the military structures gear up to the degree to which they could really be helpful, at least so far. The U.S. naval ship, the Comfort and the Hope, are potentials. It's an entirely different world, though, if you're thinking of bringing those people aboard that ship. So I can't see that happening yet, although if it does, it could be really potentially helpful. It would be extremely risky for all involved, but it would be, I think, a symbolic and real important effort if it could happen. I think part of the solidarity that we all have as it relates to the people of Liberia and Sierra Leone and West Africa and Africa in general, because a lot of the United States views Africa as a country, not as a continent with many countries. So I think one of the things that we can do is just help. There's nothing you probably can directly do, essentially, but I think this whole issue of demystifying the epidemic, especially to travelers throughout Africa, for example, is potentially really useful. And just understanding that this is one of many public health threats in the continent.
Hi, my name is Nick. I'm an MD MPP joint candidate with Yale School of Medicine and the Harvard Kennedy School. My question has to just simply do with, you had mentioned or touched upon learning from this experience in the international community. Do you view that there will be any major shifts, transformative changes, or even sort of smaller but things that are kind of meaningful? Like, will this experience cause responses in the future to be better, or is the infrastructure in place? And this is just simply how the response would play out with any given scenario, and there won't necessarily be any larger changes that will happen as a result.
Mike?
I'll comment very briefly. The international humanitarian architecture, the NGOs, the UN, the way they all collect, have not dealt with this before. It's a new thing. And it's shown us a few things so far. One is that organizations like Doctors Without Borders, who frankly have not worked a lot with other organizations, have been beautiful in the way they've worked well with other organizations and giving them capacity. It's a sea change as it relates to the NGO relations. NGOs will join together in their technical support and their technical understanding and share training resources in a way that they have not done that before. I think that from the inside perspective, because I work with them every day, I think it's an important move. And if we're successful, if we can actually come to some sense of unity as an international non-governmental organizational base and do it in a technically excellent way and a supportive way of each other, I think we can actually do really good work there. Build capacity there, and also build our future capacity to respond.
Okay. Last question.
Hi, my name is Alana Hirsch. I'm a physician, and I worked in Liberia in 2010 for 5 months at ELWA Hospital, which is the main Ebola center now. And so I'm just in a state of fury, actually. Rick Sakra, who's the last doctor who just came back, was one of my mentors there. Incredible person. And everyone who I've spoken to, who I know who worked there with me or who continues to work there, said they could have predicted this a mile away the first moment they heard the word Ebola. And so while I very much respect, that you're saying out loud that WHO should have made note of this earlier. Oh, it's still shocking and infuriates me. And I have lost a certain amount of faith in the powers that be to look after this problem, and I am starting to brainstorm with people I know about what we can do on the ground. Having spoken to nurses at the hospital just yesterday, it sounds like things are improving. She said that everyone is using gloves now, which they certainly weren't when I was there. In most days, you were hard pressed to find soap, and so that's an improvement. And she said people are cleaning with bleach, but she also pointed out problems. She said that now, if any resources come to the hospital, they are going to the Ebola unit. So other areas are suffering, and nurses are panicked. Her daughter was crying not to go to work. So it just sounds like a terrible situation still. One idea I had was of creating a telemedicine system because people there don't have much access to internet, but it's very easy to make phone calls from there. Cell phones everyone has a cell phone. They're very cheap to use and to call internationally. The main limitation would be that you wouldn't be able to visually see the patient, and also that you would need to know Liberian English. But Liberian English isn't that difficult. And there are a lot of people who have volunteered there who might be able to help. And I thought, with that system, with like a telemedicine system, we might be able to both help clinically, at least the people that don't have Ebola who have questions, and as well from an education standpoint, public health people could help just set up an Ebola hotline, give advice that people could call if they think maybe they're infected, but they're too shy to present because they are scared of the hospitals, so on. Things like that. And I was wondering what your thoughts are about that idea and who I would contact to set that up.
So Elaine, I would say that telemedicine, we're quite far away from actually establishing anything related to telemedicine. I think that the usefulness of media is going to be mass messaging. Actually, the dense cellular coverage and digital coverage throughout Liberia, Sierra Leone, and all of Africa actually can help us. Public health message, that's the stuff, man. That is what needs to get out there, both training for health providers, because the ignorance is significant and the lack of education is significant. Right. And back to your last issue or the prior issue of the pipeline, I was as infuriated as you are in terms of the lack of the supply pipeline. We have to have a fire hose of support for hospitals, clinics, mid-level clinics, all of those for supplies and resources. It just has to happen. So I think that if you have any sort of sense of wanting to push things along, it's that logistic structure to support people and our colleagues who are working in those hospitals and clinics.
Please join me in thanking our panel who have been just terrific. Thank you. And my thanks to all of you and to all of you who asked questions. Terrific audience. You were just great. Thank you.
Great.